welcome to Brava Academy, a webinar series where experts share their insights about the Brava Plus system. My name's Dr. Mara Shin, and I'm your host this evening for tonight's Brava Academy webinar. I am the clinical advisor for BRIAS, and I'm a board-certified orthodontist currently practicing in Dallas, Texas. I would love to introduce to everyone our wonderful speaker for tonight, Dr. Sagafi, who is a longtime Brava provider. She is amazing and holds a wealth of knowledge and expertise, which I am confident all of you will find very valuable in your own clinical practice. So without further ado, I'm going to hand it over to Dr. Sagafi.
Hi, everybody. Thank you, Dr. Shin, for the warm welcome. And thank you, Jeffrey Smith, for organizing all of this wonderful webinar together. I want to thank everybody for joining us. And let's get going. I'm excited to share with you a lot of the, I think, knowledge that I've gained throughout this time with the company, and it's been really fun. So let's get started. So my journey started in 2017, right from the very beginning, with the inventor, and he's a good friend, and so it's been a fun journey. And I hope that you guys will find the same as you join. So. I do want to disclose that I am an investor and KOL for the BRIAS Technologies. And let's get started. Let's talk about today a few big categories that I think as you embark upon using the Brava Plus system, you're going to really enjoy doing. So let's start with the surgical cases with the Brava Plus system. I want to go over a few cases with you and talk a little bit about the details. So for example, here for this young gentleman at 33 years and 5 months, he was really invested and interested in having skeletal change both for aesthetics and function. Yet when he came into the consult, he came in very, very emotionally, and actually with one of his best friends, because he was told that this would be too difficult to fix, and he had had previous orthodontic treatment as a teen. So when we look at him closely, you can certainly see that he's got a severe skeletal malocclusion and severe deep bite. You can appreciate that there is periodontal recession, gum recession, and some abfractions in certain areas. And he had bicuspid extractions on the lower arch. So as we continue to see, he basically has a full crossbite of the maxilla, and he had connective tissue graft as well on the lower anterior. So his case for him was rather emotionally charged, and he was excited to not only we could address his malocclusion, but we could also do it in a discreet way using the Brava appliances. As you can see in his Ceph, he has a severe negative overjet, mandibular prognatism, and maxillary hypoplasia. As So upper and lower Bravas were bonded for him. These are the Brava Plus. As you can see, a bonded upper and lower 6 to 6 with the lower premolars that were missing were not obviously there. And upper sevens, I did not bond them. We did have some, as you can see, palatal recession on the sevens. And even though our bonding is really good to crown material, which I advise you to have some of the best bonding material you can have for crowns as well, I wanted to, it was adequate to do from 6 to 6 at this point to get him rolling and into surgery. The goal of the pre-surgical phase was to level and align, and as you can appreciate, there's a bolt-in discrepancy on the upper laterals, so I wanted to create some space as well for him for future restorations. So this is pre-surgery. He had his beard shaved, obviously, and photos were taken so we could do better study of what was necessary for his simulation, for surgical correction. And you can see even in his smile line, we really have a hard time seeing the maxilla, and we can certainly appreciate the skeletal discrepancy, the flat profile, the obtuse nasolabial angle, and the prognathic mandible. So, right pre-surgery, what I do with my Brava cases, the wires come out, and then depending on the surgeon's preference, I may not put any labial brackets, or if they so wish, I will add labial brackets. So, this surgeon was more comfortable to have labial brackets than treating just with linguals or putting TADs or skeletal anchorage during a surgery. This was his protocol. So, a few days before he went into surgery, I placed the upper and lower ceramic brackets for him and removed his Brava wires. And this is what he looked like pre-surgery with the surgical pins there. And I always keep the Brava brackets because post-surgery, I want to see if needed, the brackets are already there and I can just scan for new Bravas. So basically, the curve of speed leveling and leveling and aligning was all done without the ceramic brackets. And as he was ready, as I said, the brackets and wires were added labially. And this is him post-op, post-surgery. I think the simulation that we had done and the planning was successful, and the surgeon did a great job. And he basically was placed in ideal occlusion. And as you can see, we've got some spaces around the laterals as well. This is his frontal view with the midlines on, and I think the spacing that he had for the laterals was then ideal at that point for the restorations that he was looking for. I did do his final finishing actually with these labial brackets just because the range of motion was a little bit tough for him to open immediately post-surgery, and it's great. We don't need much access, as you know, for the labial brackets, and you can continue. And he was on rubber bands, and I was able to then address the needs that he had for detailing. So this is his post-op facial changes. As you can see, we're seeing quite a bit of a much wider smile, and the profile obviously is there is still some inflammation. This is about 8 weeks post-op, but he has great changes, and he was really happy with the outcome. At this point, I had removed the labial brackets so I could send him to his dentist. And I was still trying to align that upper right seven there. So we decided we're just going to leave that little sectional there for him. And he then was free of brackets. And I did put a lower fixed retainer for him at this point since he had a graft in the interior. We've had some bone loss, and the upper fixed retainer was not bonded until his upper restorations were done. So this is the occlusal view, as you can see, of both arches nicely aligned. And this is after he had his restorations bonded at this point. He was really happy with the results that he had. It was a big change for him. And he's a very social individual, and he's public forward. It was really wonderful to also know during his Brava treatment, pre-surgery, he was on CNN, and he felt really confident that he could just be getting his orthodontic treatment and have it be discreet. So it was wonderful that we could get him to this point.
Dr.
So
Sagafi, I
then,
had a quick
yeah.
question about that one. Such a beautiful surgical case. I was wondering for these patients, especially when they need the ceramic brackets prior to surgery for like rigid fixation, is there any special preparation that you give to your patients in regards to how long they're going to be in labial brackets? Anything that you can do to help prep them for that?
Yes, absolutely. Fortunately, they understand that case by case, it could be slightly different. And I definitely like to, once we have our simulations and 3D models, to go over that with them so I can give them a much better realistic prediction of how long the labials may be, or how long in general just the post-surgical orthodontics is going to be. And so we all agree that the shorter, if we have to do anything, the shorter that it can be, the better, and especially for the labials. But I do explain to them that depending on the range of the motion of the skeletal correction, the musculature is going to take a little bit longer for it to settle in. And so that might mean that it might take them longer to get into enough opening for me to be able to do what I need to do for them. particularly getting any scans that I might need to do. It's nice if we have finishing wires ready to go. At that point, I don't really have to get a bigger wand in their mouth, and they're used to me working in there, and I can just slip in a finishing wire in there. So
Sure. Awesome. Thank you so much.
great. Thank you. Thank you for that question. So the next surgical case was a younger patient, and she was extremely timid as well. It's really interesting. I think a lot of us can appreciate the anxiety, the level of emotion that goes through, especially as you grow into these younger adults. And when she came in, she literally was saying, if I could have surgery tomorrow, I would do it. And interestingly, she called my office up because she was hoping to have her surgery done at Maryland University and didn't realize that we would be doing any orthognathic cases in private practice. And she called to see if we could just take her staff because she lived nearby and that she was going to then, head out that way to the university to do her surgical treatment. And so it was wonderful that we could offer her not only the surgical corrections that she needed, but also Brava, which she was very excited about. As you can see, even in her three-quarter smile, and I'll get a little closer for you here, that's her smiling, and that's her with her bite. You can see the prognathism that she has, bit of an asymmetry. And once we look closer, you can certainly appreciate the anterior open bite, the cross bites. And thankfully, she didn't have a lot of crowding, but certainly this is something that took some good planning to do. Her arches were relatively leveled, and a lot of these patients have already had previous orthodontic treatment. So she certainly was a surgical case. As you can see, curves had to be leveled and to prep her for surgery. And you can appreciate here that she's got great level of bone. Root lengths are pretty good, a little bit shorter on the maxillary incisors, but nothing worrisome. She did still have her wisdom teeth, and we tend to have the wisdom teeth removed 6 to 9 months prior to surgery for the cut area to have bone fill in those areas. And this is her basically during her leveling and aligning phases with her upper and lower Brava Plus systems. And she acclimated to them beautifully. As you can see, she's also keeping them really clean and nice. A lot of these photos are taken as patients just come in, and we don't necessarily always have them brush and floss before the photos, which would be ideal to do, but they're pretty self-cleansing in a lot of the designs. And she's leveling nicely in both arches. Then in her case, instead of putting her in labial brackets, I put her right into her retainers pre-surgery because she was leveled and aligned. Wires come out. She was getting her scans for her splints to be made pre-surgically, and obviously we don't want any of the teeth to move. So she was very compliant with her retainers, and that's 24/7 except eating and brushing. And then she went into surgery. And this is her composite post-surgery. And in this case, as you can see, the surgeon used their plates, used their screws to stabilize the arches, and was using elastics to these, which was great. So, and a closer look at her profile changing, her smile, the skeletal discrepancy, the asymmetry. I mean, she was just so, so thrilled. And this is her occlusion. And I do sometimes use refiners with my Bravas, kind of the same with labial braces. Most of the times, we're finishing our fixed appliances without the need for anything, but as needed, it's nice to be able to offload any of the fixed appliances and do some refiners or aligners to do some finishing touches. So on the upper here, on the upper left 4 and 5, I'm doing some finishing touches for her with aligners. And she's actually even also considering potentially getting some veneer composites on number 7 and 10 on her upper twos, just because now she just sees everything and she's so happy and she just wants to really enhance her smile. And she's really thrilled. I am as well. Great results. As you see, the wisdom teeth were taken out, and she was a 2-jaw surgery. And so this is the next case that I'd like to go over with you. She also had had previous orthodontics treatment, and she was done around 13, 14 years of age. By the time she came to me, she was 21 years old, and her dentist said to her, you need to have orthodontics. And she said, well, I did have ortho. And as you can see, she was still amazing when I met her with using her retainers. Her arches were really nicely leveled and aligned. And she continued to wear the retainers, but then obviously she also grew vertically, and her contact points are only on her upper and lower first and second molars, and even a little bit lighter on the left-hand side. So she was not in any pain. She didn't have any joint issues. She didn't have any speech or eating issues, but we all know that this is a type of occlusion that needs to be corrected and addressed. And at the same time, if we attempt to do this orthodontically alone with dental extrusion, it's just not going to be a very stable bite. So I went over that with her and her mom and explained that she would really best benefit from doing orthognathic surgery in conjunction with orthodontics. And being a college student, she really was thrilled to know that we could give her a lingual option, and not have to worry about labials or aligners. So we did the surgical simulation, and I actually did not do any brackets or Brava for her initially. What I wanted to do is to have her go into surgery, get the most soft occlusion that we could get, which I was hoping would have been probably like 90% to 100%, and then do any minor rotational corrections that were necessary that you could see around the canines and establishing an ideal occlusion. But that didn't quite work out as I had hoped and planned, because unfortunately she came out of surgery with this type of bite, which is not an ideal situation at all to see post orthognathic surgery. So, what I was really happy to have experienced in this case with her was to know that I could treat cases in reverse with Brava when things kind of go wrong, or let's say are not planned. They go as not planned. So it was nice to be able to see that the technology can still deliver what I needed. And so this was her post-op. As in the next few weeks, as her range of motion opened up a lot more, then I did her scans for her. And this is back in the day before Brava Plus. So I wanted you guys to also see a little bit of the evolution of the technology, which has been beautiful to experience, and it's only gone better. So as you can see here, these are a different kind of brackets, and the springs are engaged in these brackets. They are not custom made. In this case, the Brava Plus brackets are custom made, which gives us a lot better adhesion and also connection between the arms and the brackets. In this case, these brackets would have little cleats on them, and there could be wear and tear, or they were much more fragile. And as a result, if the cleats would come undone, then the arm would not engage as well. So it's wonderful now to see with the Brava Plus system, we don't have. At this point, she had had those upper and lower bravas in, and I used some ceramic buttons, as you can see, to both in conjunction with the arms and the buttons close the bite, both posteriorly and anteriorly. In the springs, I had built in minor extrusions, both on the upper and the lower, and then supported it with the elastics. So it was great that her elastic use period as a result would be much shorter. And that's really important, I think, in pleasing the patients. So we got nice overjet and overbite. And she'd had a BSSO with a counterclockwise rotation. And at this point, this is her in retention. And as you can see, there's ever so slight bit of opening. As we know, in a lot of our open bite patients, we also have a tongue thrust habit that we need to be aware of and be addressing. So this is when she had still her fixed retainer on the upper, and I encourage her to make sure that she uses her Holly retainer as well with her tongue crib, to be able to help the crib, the tongue stay back some more. But she was one certainly very happy patient, and was thrilled to head off, back to college. And her treatment overall was a very quick one. She literally went into surgery, and the day of her surgery, it snowed here in DC, which doesn't snow much around here, enough that she ended up staying in the hospital. She was not going to be staying, and her overall course of treatment was under 6 months, closer actually to 4 months for her, but from the beginning to end, and records and putting the Bravas on. So she was very thrilled, and so was mom. I'll go to our next section on treating congenitally missing laterals with the Brava Plus system. And I've had some wonderful, wonderful surprises here. And when I say surprises, it's just nice to know that you can depend on a system. And so here I'd like to introduce to you a dental student who found me, and he's currently a third-year dental student, and will be graduating soon. And as you can see, he is congenitally missing his laterals. He's got large arches and some excess spaces. Overall alignment in both arches is good. His central diastema was his main complaint, and the spaces behind the canines. And so he wanted to see his options. And so let's take a closer look. Before that, I also want to point out on the lower anterior area, you can see how he had a two-step occlusion there. And so the options that I talked to him about was we could certainly do restorative options, as well as orthodontic option in conjunction with restorative options if needed. But he also understood that if we wanted to close the diastema, I needed to have increased overjet. And for that, we needed to have a lower incisor extracted. So looking over his panel, in general, good bone level in both arches, slight bit of shorter roots on the lower incisors. And you can see those canines are really where in the lateral spaces. So I was happy to see that he was okay with doing a canine substitution in this case. And he had his upper and lower bravas bonded. And as you can see, this is also one of the previous generations of Brava. And we always do our bondings prior to the extraction of a tooth that's going to be extracted. So we just don't extract that. And basically, the main reason is we don't bond that, I meant to say. Basically, the main reason is if we extract the tooth, the teeth will start drifting around the adjacent teeth, and our IDB tray is not going to bond as predictably. So we want to make sure that our brackets are exactly where they need to be, and our wires engage, and patient goes off to have the extraction done. And that's the protocol that we followed here. And as you can see, the maxillary diastema is becoming smaller, and same as we're moving through, you can now see at this point the lower incisor extraction space is fully closed. The curve of SPE is leveling, the upper diastema is closed. And as you can imagine, the tissue between the canines and the premolars is going to be a little bit thicker, gives us resistance to the closure. So this is in his next round of Bravas that you can see in refining. We're getting the molars to be upright, that they weren't as upright on the upper arch in the previous set, and as well as getting that curve of SPE on the bottom, leveling and idealizing the lower arch. So I think he's going to need some gingivectomy to be done distal to the canines to help us close the remaining spaces that we have, and also potentially mesial to the molar. But he's thrilled. It's a predictable option to be able to offer, and we are going to be finishing him also soon, because he's a dental student, so he doesn't come around too often. And I have to tell you, the fact that the Bravas are on the inside, I find that sometimes patients don't come as often as they used to do. The metal braces gets the patients through the door much faster than the Bravas do. They get used to it, and it's doing the work. So next patient that I want to show you is this lovely gentleman, 34 years old, and he comes to me with this problem. He has been wearing a flipper for several years, if I'm not mistaken, was close to 10 years. this is not a missing lateral, but it's in the aesthetic zone. We need to be able to have great options that we can give our patients and have confidence in what we're trying to plan for our periodontist or oral surgeon who's going to place the implant, or for our restorative dentist who's going to restore that tooth or do bridge. So in this case, this patient came to me from his restorative dentist so that we could have ideal spacing for upper right central, and making sure that we have the adequate overjet that we need, so that teeth needed to be uprighted and aligned, and the torque on the lateral, upper right lateral, needed to be addressed. So in that spirit, with that planning, the upper and lower Brava Plus brackets were bonded, and same for the lower. I was just going to do, I did some interproximal reduction on the bottom for him so that I can level and align and retract the lower, create more overjet. In the meanwhile, he had also had a lower right 7 extracted, and we were ready to sequence everything for him for an implant on upper right 1 area. So this is when we had to free ourselves from the flipper, and he understood that. And here with his general dentist, the dentist bonded basically a pontic to the lateral for me. And I always try to pick the tooth that's going to move the least amount, so the pontic stays as stable as possible, or it doesn't get as crooked, but we don't always have that option. And we also have to balance it out with the adhesion to a tooth, as the restorative dentist needs to be comfortable with doing this plan, because this patient would be in the restorative dentist office otherwise every week, and that's not manageable. So the pontic is bonded, and in this case, it was bonded to that lateral. Sometimes we place wires in the pontics. A lot of times I allow them to kind of put their composite over the bracket as well. I just want to make sure that they don't come into the spot where I need to remove the spring. And the big thing is he gives me the right size pontic, and this way it's much easier for me to also plan how I want to close the space. And eventually the space was closed with the size of the pontic that he had delivered or bonded for me. And fortunately, we had 0 debonds, and patient obviously took great care of it, not to bite into any foods with his teeth. And it was greatly placed, and we were able to get through the treatment smoothly. And at this point, his wire is removed on the upper. He's in a retainer, and so that the implant was placed, and inside the retainer, I painted basically some composite for him. So he had an aesthetic option while the tissue is healing, and then he's on the way to get his permanent crown. And he was really thrilled. He did not miss his flipper at all. So this was great to be able to do this all under a year again for him. This was no more than around 7 to 9 months of treatment. Sometimes what takes a little bit longer is creating that overjet and the planning, going between back and forth between the offices and coordinating same day treatments that are being delivered. But he was also really thrilled. And this is where his lower was, where that lower right 7 was extracted prior to starting treatment, and during the Brava on the lower. And he had an implant placed on the lower right 7, and he had his fixed retainer on the bottom. So the next case that I want to share with you is this beauty. When she first came to me, she was 13 years of age. And as you can see, she's got mixed dentition. She's got a really deep bite, class 2, div 2. She's a skeletal class 2 as well. And we're congenitally missing both laterals on the upper, and we've had full canine substitutions that have occurred. So obviously, my wish is that the parents would say, let's leave these canines forward and in place, but they chose differently. And they wanted to have the spaces opened for Maryland bridges and future implants. So as you can imagine, for us in general in orthodontics, this is a pretty involved treatment plan and lengthy. We know very well that some of our these kiddos that have congenitally missing laterals, in some ways they suffer because their orthodontic treatment just is ongoing and ongoing. So in her case, certainly her canines were extracted, the baby canines, and Bravas were bonded. I will walk you through, have you look through the different stages here. As you can see, I even put a bracket on the upper left E that we normally wouldn't, just because I wanted to get as much anchorage as possible on her as she was going through this mixed dentition, so that I could start opening her bite and start moving teeth. And it's exciting to see that I did not have to use TADs in a case like this, that normally I would automatically plan TADs for a case such as hers, that I would feel I need to do a lot of heavy duty anchorage setup posteriorly to be able to retract these canines. And also retract, obviously, the roots have to be upright and out of the way of the future implant positioning. And different designs, as you can see. And eventually, I did have to switch her to labial because at this point she was 16 years old. And this was a case where her dentist was not comfortable with putting Pontics onto adjacent teeth, or the same way that I showed you in previous case. And he was very comfortable with just having Pontics there, and basically was a proponent of that and encouraged the patient and her mom to go to labials, which again, there's nothing wrong with that. It's great that we have all of these options. And at this point, I also continued this way to ensure we've got the spaces that we need, and was able to establish this for her. So she was in the upper ceramics for no more than maybe 4 to 6 months. And this is the anterior with the Bravas. And I'll go back here again, and then was able to just get her into the labials for the finishing touches there. And this is basically the Panorex. As you can see, the roots are nicely aligned, and she's going to be able to have just successful and uneventful placement of implants for her. So we were thrilled that we could give her this option. She's just this beautiful young woman now, and just very social, active. So we wanted to certainly make sure we could give her coverage in the front aesthetically. And as you can see, she's a class 2 occlusion. So in the future, if she's going to have orthognathic surgery or not, to just make sure that the occlusion is ideal, which I don't think the parents are going to, but this is where her soft tissue will rest and her occlusion. So this is her. And this is her in her retainers with the Pontics. And she went through graduation this past May. And now is the next case that I want to go over with you. So this young man is missing, congenitally missing upper right lateral. And he has the upper left lateral. And as you can see, it's a little bit smaller. We can see a significant midline discrepancy, slightly deep bite, but in general, the leveling and aligning is good as we look at both arches. Again, we've got a full canine substitution here. And on the lower arch, we've got moderate crowding, and it's hard for him to keep everything clean. So again, in reviewing options with parents, one option certainly was to keep the canines where they are and do maybe some restorative aesthetic changes, recontouring, or drive everything into class one occlusion and have implant replacement. So certainly that sends shivers down my spine when parents wanted to do that option, and prosthodontists said, yes, that's the best option. We want to get our canine class one occlusion and not do any group function on the right side. And certainly they want to hide this and in terms of appliances, and did not want labial. So I was thrilled that we could do it with the Brava appliance. So if you look at the occlusion, we can see we've got a good 4 to 5 millimeters class 2 occlusion bilaterally. And if you notice, the upper sevens are already in his mouth. So as you know, prognosis for distalization significantly is reduced, and relapse as we are distalizing into class 1 occlusion is much higher. And that's his pano, nice and healthy. And of course, wisdom teeth are right there behind around the corner. So I decided that I was going to distalize him. I used the pendulum appliance for distalization, and I started his Brava on the lower arch for leveling and aligning as we were distalizing on the upper. We were having very good, successful distalization. Obviously, this was all pending on how successful this stage would be. As you can see, I do have some anchorage loss in the interior. We've lost some of our spaces there. This was expected. A lot of times in these cases, I will support a pendulum with a headgear as well at nighttime. He was not a big fan of the headgear, needless to say. So a little bit of anchorage loss, but I was thrilled that we were able to get the amount of class 1 positioning of the molars, and the premolar is sliding back, as you can see nicely, but we've got our work cut out for us for the rest. So at this point, for my pendulum cases or any of my distalization cases that I do, I will distalize, whether the headgear, whether the pendulum, and then I will debond and put my patients immediately in a retainer in the transition time for Brava. At this point, he was scanned with the new positioning of the teeth for the next, 4 weeks or so until I receive my Brava for him, and he wears the retainer full time. As you can see at this stage, the Brava had already been bonded, and retraction of the canine was already started. So the way I built these treatment plannings in my planner, I basically ensured that we've got maximum anchorage in the posterior, and I will have my specifications for that in terms of the springs or designs. And then fives are bonded, and everything else is bonded for ready for retraction. You can also notice that there are buttons for the class 2 elastic. So always in my distalization cases, I will support them with the class 2s as soon as possible. And this is one of the things I do love about Brava, that I can just jump on my elastics right away. You can also see a loop between the upper 1 to 1. And as everything is distalizing, I want to make sure we're not opening a diastema. So that loop is intentionally there. So at this stage, our alignment in general is really good. And you can see that we've made enough space where a pontic of that size was bonded by the dentist, and he's put a wire through, and he's crept up a little bit onto the bracket for the Brava Plus. And we were really thrilled that he was able to do that for him. And this is his Ceph. I think we've had a little bit of growth too, which I'm never going to say no to. It's wonderful to be able to get some stabilization that way, and I was really thrilled with this outcome for him, and definitely the lateral, we have a little extra space there too to bond, and the occlusion is going to settle in nicely once I finish his detailing. And this is the anterior. And as you can see, the upper anterior has to line up better and move the upper to the left side, patient's left side, to get midlines aligned. They were really thrilled, and he's off on his vacations now, out of school and traveling abroad. So we had the pontic bonded a few weeks ago, actually, for him, and he's been doing great with it. It was a test before his travels to make sure that they can handle this. So if we're obviously in this section, we're going to be looking more at adults for veneer and and I am going to get right into it. So this gentleman came in, he was referred to me by his general dentist and basically told him your malocclusion is really off. He just wanted a nice smile, and Dr. Martin told him, well, I can give you a nice smile, but I can't save your teeth. And if you stay in this malocclusion, you're going to lose your teeth probably. So he was very motivated to come in and address his malocclusion, but he certainly wanted a very aesthetic option. So again, it's wonderful to feel the confidence that I have in the appliance with the Brava Plus technology, and basically being able to take his smile from where he was to this smile. And he has veneers on those laterals at this point. So let's take a look at his case a little bit closer. Roots are looking great, and alignment in general was nice. It was a matter of really getting the expansion that we needed, and getting him to have positive overjet and overbite, correct the anterior open bite that he has. And if you can see, he's got a very reverse smile line here. Obviously, there is torque that's necessary for correction of the root on the lateral, and he's got a very V-shaped upper and lower arch, particularly the upper, I should say, not very, but in general, we needed to establish U-shaped arches and correct the anterior open bite, and give him a better occlusion. So upper and lower bravas were bonded for him, and as you can see, the alignment is coming along well. Same on the upper, you can appreciate the arch shape changes that he has. I do like to add buttons as needed, but again, in the bravas, I will build extrusions and intrusions, and I will assist it as needed for whichever side. And midlines are moving on. I love the fact that the torque on the laterals are getting corrected, and the spacing that's really important to the restorative dentist on the upper incisors is getting settled in. So this is where the general dentist was happy to have these spacings and alignment for the upper arch, and his occlusion is corrected. The expansion is completed without overexpanding him to respect the biology on the perio, and establishing stable occlusions. He was really, really thrilled. This is prior to getting his veneers. And here, and as you can see, there are no springs on those laterals because I was coordinating with his dentist with the scans that he was doing and what he was building to do within the lab. So what I do love about the Bravas is it's just given me a whole other way of treating these restorative patients. I will have them in these wires, go to their dentist, and come back with beautifully bonded veneers, with beautifully done composite bondings. If we were in labial braces, we have to take those off in order to be able to do that. If we're doing aligners, the aligners aren't going to fit. So timing becomes, again, very crucial, and it takes a little bit more planning for those cases. Then here, I just clip those springs off, grab the brackets off, and off they go, and everybody else kind of stays where they should as they have their arms. So, and this is his final at this point, with the fixed retainers in place and the alignment already done and the veneers done. So he was really thrilled, as well as we were. So the last case that I would like to share with you is another adult restorative case. As you can imagine, she was not ecstatic about her lower arch crowding, and she's got procline upper and lower incisors. She's got mid-arch collapse. The mid-arch collapse that she has really has to do with the fact that she was congenitally missing upper first premolars, and basically that area has a bony defect, and she was given these bridges with the Pontic for several years ago, and it served her well. But at this point, she was looking for a better occlusion, as her dentist had described to her, and as well as better aesthetics. So when she came to me, I let her know that she's a extraction case, that we would take the lower fours out, and I wanted to time the sequence of getting her bravas on with the extractions. So this is how she looked in her pano with the roots, and bone level is healthy. And we can see the proclined incisors, both upper and lower. So per usual, the lower brackets are on, the lower Brava is on, but except on the fours that were going to be extracted. I don't necessarily always get on the sevens from the very beginning, just because I want the patients to have time to acclimate to the Brava. As you know, just even when we put brackets on the sevens, it's harder for patients to acclimate to those. So I kind of build these tips and tricks and built through the treatment. And for her, we took out the lowers, but on the uppers, I just bonded her brackets. I put some wax on her brackets so her tongue would be comfortable, and I did not plan to put her upper Brava in until the lower crowding was resolved and the lower arch was basically in positive overjet, because we had a lot more work to do on the lower. So I did not want her to have to go into negative overjet as I would upright and retract the upper incisors. And basically, once her lower, as you can see, the crowding was much less, her crossbites were addressed. I put in the upper Brava, extractions were done, and pontics were removed so that we could now simultaneously have both upper and lower arches move at the same rate, and then minimize the size of the holes or the time that she has those holes. She was okay with not having the option of trimming back these crowns or having bondings. So we felt that this was a good way to go about it for her. And interestingly, as you can see, the upper right space is closing faster than the lower. So I was definitely happy that we had made that call. You can see the overjet is increasing on the lower. Her midlines are aligning and spaces are closing nicely. And at this point is when she went back to her general dentist, and I wanted her to see if these are the sizes of the crowns on the upper she wanted to maintain. And if so, then I would close the rest of the space. And if not, then if she thinks that we have the green light to remove the upper Brava, and so she can start doing the restorations on the upper fours, which was the case. They wanted to change those restorations. And as you can see, for the lower arch, the sevens are now in the system to help with further anchorage and better alignment of the arches. So she went in, she did the restorations. Despite that, we had a little bit of space still. And so at this stage, I did just some aligners for her just to close that. And she was really thrilled to be able to get the occlusion that she wanted at the rate, at the speed. It was about an hour, a year and a half worth of treatment, and we got great occlusal contacts. And so she was very happy with that result. So I'd like to use, for example, this patient as an example. So if we look at her record here, she is a retrognathic case, and also wants to significantly improve her profile. So it's going to be an advancement, certainly of the lower jaw, but most likely two-piece or possibly a three-piece Lafort as well. So in this case, and if we look here, we really need to rotate that mandible and get her into much better occlusion and soft tissue profile. So for her, we're doing 4 bicuspid extractions, and mainly because I need to make sure that the surgeon has a lot of room for the advancement of the mandible. So as you can see, the blue bar is what shows what the Brava is going to do in terms of the movement. And I have really, in very great detail with my Brava planner team, have planned it this way so that the lower, they are retracting for me, but the upper is not being retracted anymore into that extraction space, because my plan is to put tags distal to the upper fours so that I can protract the 6 and the 7. And the main reason why we're doing that is because we wanted to keep anterior anchorage for her soft tissue profile. And I basically just need help from my Brava to be able to level and align the interior, maintain the soft tissue profile that she has. We don't want to compromise that. And then I'm going to be placing my tabs. So in my plan here, I have basically gone back and forth a few times, and we have discussed different levels of what I'm going to be doing for the patient. So I'm setting all of the plan, and they are really building it into the Brava format, which is fantastic. So in this case, you can see then the auxiliary is where the surgery will come into play here. That will be This is harder for it to show on the planner at this point, but the Brava planner itself with the movement of the teeth is there. So I think this is really exciting because it's also a really great visual tool for my patient to see. We love doing that before and after photos, and also to be able to show her what the Brava is doing and then what I'll be doing as well. So we're going to be creating great overjet here, and then he'll be able to advance her on the mandible nicely. So I'm glad that I was able to share this with you.
Amazing. Well, thank you so much for your presentation, Dr. Sagafi. Your cases are amazing, and we really appreciate your time today. And that concludes the presentation portion of our webinar for this evening. All Brava Academy webinars are recorded, just FYI, and made available on the Bria's YouTube channel. And also a big thank you for all of our attendees, and thank you for the patience as we were doing some technical issues at the beginning. If you guys have any more questions, please submit it on the Q&A tab on Zoom, and we can go over the rest of the questions shortly. Um, so, Dr. Sagafi, you seem to treat a lot of adolescents. What's your experience with adolescent comfort with the Brava appliance?
Oh, fantastic. Oh my gosh. I find that with the adolescents, in general, 90 to 95% will come back, and within a week, week and a half, they are already in a very good place. Myself, as a Brava patient, 9 years ago. It took me 4 to 6 weeks to get used to things. And then adults come in and they're all like, okay, it's taken me some time, but it's expected because kids are adapting constantly and they're just busy elsewhere. With adults, they tend to focus a lot more on the treatment that they've selected and what's going on. And that's why I think setting expectations is really important. And this is why about, I would say, 60 to 75% of my practices are Brava, because when they come in for the consult, I explain it to the parents, and most of the times the parents say, well, why would someone choose something else? And I basically love it when parents send us a quick email and say, hey, Johnny has acclimated already and it's only been a week and we're fine, we're doing great, because we tend to check in with them. So I think adolescents, they in general do great with it. Just like any type of case that we carefully select, I think it's also important to select. If you find you've got a fussy kid, and if you find you've got someone who is in the chair just already uncomfortable, you should know that that patient is probably going to be uncomfortable with labial braces, with Invisalign, and with Brava. So you want to go to something that's least obtrusive potentially for that type of patient. But adolescents do wonderfully. If you can just get them to stop eating some of these things that I'm shocked adults come in and say, we remove the brackets, I've got to put some force to remove them. And it's great. It's fine. They do great. But when I tell them, oh, I had this kid just come in and they had some broken brackets, they just wonder, they're like, how? So that's the only thing that sometimes comes with the adolescents. But otherwise, they do really great, and get some good reliance bonding, and you'll be totally fine.
Perfect. Couple more questions still going with your adolescent patients, and I know you see a lot of mixed dentition patients. What's the earliest age you would put Brava on a kiddo, and how do you find their hygiene to be?
I love that. Okay, so I actually think if hygiene is not ideal, they are a much better Brava candidate than braces or Invisalign. Invisalign, I think it's self-explanatory. Those trays are going to be dirty and food is going to be in it. It's just not a good situation. Um, So with the Bravas, the worst thing that can happen is, which is already bad, but the worst thing that can happen is they're not flossing or they're not cleaning around with the water pick enough. And the good thing is the water pick does not break these arms. So a lot of the kids like the water picks and use them. Because I find it that if their hygiene is not good, the worst that can happen is I'm going to get puffy gums, but I don't get decalcification. So, and the decalcifications on the labial, I mean, it's irreversible, and then it snowballs into everything else. So, we do have to do more like studies on this, but I love the fact that I have much less caries rate in my office, like much less significantly because I have a just much higher percentage of Brava cases. I have much less gingivitis issues. I do find it that the kids that are just not going to brush very well are not going to brush in the Bravas as well very well, but the consequences is not as severe. So that's what I do love about it for kids that are not good brushers. And then to answer your question about how early can we start, I've had kids that have cross bites and that I have started them, and they're in mixed dentition with cross bites, and it's been a great appliance to pop in because they rest on the brackets, it props them open, and so as young as 9, 10. I'm very comfortable doing that for them, and it depends. Some of the kids that are younger, if they're more mature, why not? And especially these are sort of like 2x4 looking. So there's less to take care of and less to have to even worry about. So I would say anywhere from 8 and up, you can be very comfortable with the 2x4s to do, especially if you're going to start them maybe on the upper first and they're excited that they've got something in there. And then you phase into taking care of the bottom where the tongue has to get used to it. They really don't care about the upper having some very temporary speech impediments. So with the younger kids, some of that stuff is just less of a worry as well. So I would highly recommend considering them for the right cases. Absolutely.
Yeah, I totally agree. Kids are the best in general. Another question, how often do you see your patients during treatment? Is it the normal 8 weeks that people see for adjustments, or do you go longer?
I absolutely love the possibility of going longer for all the reasons. I practice in a region where everyone is so busy, running around with the kids, the private schools, the travels, and the adult patients themselves are in these big companies or all over the place. So it's nice to be able to set them out for beyond even 8 weeks. I have college kids dotted all throughout the country. So I basically see them during their spring break, during winter break, or during summer when they come home. And again, when they come home, they're traveling. So they basically come in, check things. I have them on dental monitoring. I would say the one rate limiting factor is if I have to make spaces. So if I have to do IPR, then I do want to see them more frequently so we can stay on course. And but if it's extraction cases, if it's elastic cases, I've got patients that I'm prepping for surgery that are in Bravas in California, and they're flying over here to get their surgical workups done and have surgery here because home is here and college is there, and parents are going to take care of them here for surgery. So I think in general, you're still going to want to gauge it that way, but you're very well able to let them go for 8, 10 weeks, a big chunk of these patients, if not more.
Awesome. That's great. I guess one follow-up question I had for you, do you use dental monitoring in your practice at all?
Yes, and I love using it for all of my patients, whether they live right next door, or they are somewhere in a different state. And patients absolutely love it with their Bravas. Like they just feel like they have the highest technology in their mouth already. And then the fact that they can scan and I can say, well, it's time for you to come in because I want to get you into a new Brava. Or they don't even make any appointments and I can watch them with their elastic use and I can draw on it and change it and tell them stop using it on the left-hand side, but now use it on the right side. So dental monitoring is amazing. It's just it's a really great combination with Brava, I think. Yeah.
Awesome. Well, I think that concludes it for our questions. But thank you,
Right.
everyone, again. We really appreciate your time. Thank you so much again, Dr. Sagafi. We
Same
loved your
here.
presentations and hope to hear more from you soon.